This is our Dementia Care Aware webinar for May 2024, Caring for Caregivers of Older Adults with Dementia. And I'm going to introduce our speakers in just a second. This is a really wonderful talk. I've heard a lot about this program before, and I'm really excited to tell you about their backgrounds and how they came to share this with us today. No one today has any relevant financial disclosures. I'm over here on the right with the really zoomed in photo. I'm just our moderator for today from Dementia Care Aware. But I want to introduce Robyn Golden and Diane Mariani, from Rush and Rush University Medical Center, both key developers and disseminators and active creators of this program. So I think as I mentioned, I've already heard this talk, and I think this hits on such a key component of Dementia Care Aware and what we're hoping to do by building a recognition of caregivers into the work that we're doing. A few housekeeping items, again, as a few more people trickle in over the lunch hour Pacific time here. We do have ample time for questions today, but please, as we go through the presentation, feel free to put those questions in the Q&A or the chat. A little bit, we prefer the Q&A, a little easier to manage, but we will be looking at those throughout. I will be answering some of those throughout if I can, and making note of them so that I can really curate a Q&A session. So please feel free at any point to put your questions there. Towards the end of the webinar, we're going to have information about how to claim your CE and CME credit. We will have the recording of this webinar and the associated slides up within 48 hours on our website. And we also have we'll have this webinar, and we already have all of our past webinars up on our YouTube channel. A reminder about our program, if any of you are joining us for the first time, that we have several offerings. This is really part of these monthly webinars are part of our educational and training opportunities. We also, of course, have our online training series on dementia screening and associated issues, as well as dementia care in general. And then we have our podcast, which is another opportunity to hear a lot of the same material, but in a more conversational format, and also get continuing education credits. We have supportive programs if you're looking to implement and include dementia screening in your clinical practice. If you're at a systems level or at a practitioner level, we have different resources for you. One would be our warm line, where you can call and talk to a live person Monday through Friday to ask questions about dementia screening and care. And we also have practice support and ongoing interactive ECHO case conferences, which are more or less, I think, fully subscribed, but there's also a lot of other opportunity that signing up for those or looking at those offerings can connect you to. I think all of the current groups have further ECHO offerings after these have wrapped up. In general, of course, if you're looking to learn more about the program or how it can help support you in clinical practice, dementiacareaware.org is a good resource. And if you're having trouble finding something, just shooting us an email at dca@ucsf.edu. As many of you have already heard, I'm just going to go over what our basic training is, but we have a core module online called the Cognitive Health Assessment, the Basics, and it just goes over our screening approach, why screening is important, what you would then do next immediately, and how you'd set yourself up for the next steps in an evaluation. This is a 1.5 credit course on our online learning platform, which you access through our website. And before I quickly go over what it is, I do want to also let everybody know that and these have been really, really popular and I think really enjoyable for folks because they're live and you can ask questions, but we do the same training that's in that online module as a 1-hour live format. And there's multiple going on every week with our partners at UC Irvine and the Alzheimer's Association. So I really encourage you to sign up for those, if usually at the lunch hour. Really encourage you to sign up for those if those would be easier for you to accomplish than our online training. And so as we launch into the topic, and we're there now, but I want to first explain why caring for caregivers is so important. It's so important that we've incorporated it into the moment of dementia screening. So our approach that we promote and teach on with the cognitive health assessment is to use evidence-based tools and use a 3-step approach to screening. So one, a brief history. This is hopefully something you're already doing with patients asking just briefly any concerns about your memory. That would be one example. Or it's already part of the history because they've presented with a complaint or some obvious sign of a cognitive decline or symptom. Then you use a validated tool for cognition and function, and we show you what tools you could use and how you could use either of those with the patient or with an informant. And then finally, a very quick, almost like a checkup, just quick moment to acknowledge and see if that person has a caregiver or a care partner, and to document that. And part of that is to really get us set up to understand that a care partner or caregiver is a foundational part of someone's care if they're having any functional or cognitive decline, and something we need to know. If they don't have anybody who's filling that role, also really important to know. So that's how we get to our topic today and how essential it is, which is caring for caregivers. And I already introduced Robyn Golden and Diane Mariani, and I will let them say another word about themselves and the upcoming talk and turn it over to them. Thank you so much.
Thank you, Anna. So nice to be here today. Diane and I were on campus in March and had a wonderful time, and maybe some of the people we met then are on the Zoom and we say hello to you. But we're constantly excited to be working with you in lots of different ways, have the privilege because you're doing so many innovative and important things at UCSF. So thanks for having us. And here's our learning objectives for today. Discover strategies to promote engagement with caregivers of older adults, identify various screening tools to assess caregiver needs. I got a call just this morning from one of the proprietary places out there who just bought one company versus another, and they're trying to promote their assessment screening tool for caregivers as part of the guide model that has come out. So it didn't take long, at least for me, to hear that people are jumping into this new guide model, a new payment system for dementia, folks with dementia, and having some strategies that we can improve our delivery of care according to them and pay for their innovation. So I do sound a little snarky about it, but we should see a lot more of that too, I'm sure. Determine workflow strategies for delivering assessments to caregivers and formulate ways to integrate caregiver identification, assessment, and support into practice. So next slide. So we probably know most of this, but we are pulling from the most recent report in terms of Alzheimer's and other dementias. And according to the 2024 Alzheimer's Disease Facts and Figures report, an estimated 6.9 million Americans aged 65 and older are living with Alzheimer's dementia in 2024. And we thought that, the numbers seem to be increasing. If we went backwards instead of forwards here, we'd see an amazing growth in the numbers. And 73% are age 75 and older. And the number of and proportion of Americans with Alzheimer's or other dementias is expected to continue to grow in coming years because the risk of dementia increases with advancing age. And the population of Americans age 65 and older is projected to grow from 58 million in 2022 to 82 million in 2050. So the numbers are sometimes just hard to wrap your head around. Dementia, of course, is often underdiagnosed, and if it is diagnosed by a clinician, some people appear to be unaware of that diagnosis, of course, for various reasons. I'm sure denial being a big one of them. A large portion of Americans with dementia may not know that they have it as a result, and some studies indicate that underdiagnosis is higher in Black and Hispanic older adults. A number of potential harms may result from a missed or a delayed dementia diagnosis. So many people think, falsely, oh, why would someone want to know? So they don't emphasize this point, but this includes delayed access to treatment, less time for care planning, and higher costs of care as a result, a negative impact on the individual's physical and mental health, or the mental health of their family members and potential caregivers. Of course, more research is needed to better understand the potential harms of delayed or lack of diagnosis. There's still a fair amount of controversy out there, particularly among primary care physicians who go back and forth very often. Let's go to the next slide. So caregiving in the US, it's, very hard to talk to someone, to go anywhere where someone doesn't start. Once they figure out what you do for a living, they often start talking about their caregiver experience, and more often than not, their caregiver experience with someone with dementia. And we lack a comprehensive plan for long-term care in this country. Caregivers happen to be the de facto answer for that. But we really, it's not the best thing that we're relying on family caregivers to be that backbone to help our aging population. Although many family caregivers find meaning in this role and take it unwillingly, they often experience related physical, emotional, and/or financial costs that they weren't necessarily prepared for, nor can really handle at times. So very critical. Next slide. And then you can see again how many people, and they say people who are caring for someone with dementia, it's even a more complicated caregiving journey or experience. And we see that more family caregivers report their own health as fair to poor. 23% of Americans say caregiving has made their health worse. And, a lot of the literature and the evidence is absolutely showing that. And to get a sense of who today's family caregivers are, there really has been a closing the gap a bit between men and women. Used to be many more women than 61%. More and more men are caring. And you get a sense there who the generations are that are caring. Boomers still the predominant group. 45% had at least one financial impact as a result, and 61% of these caregivers do work. So it gives you a sense of how complicated it can be for them in terms of being at work, attending to work, but also running potentially home, having to take time, all the rest. Let's go to the next one. So these are stressors reported by caregivers of adults with dementia. People with memory and processing problems see an average of 4 different physicians every year. And more than 1 in 4, 27% see 5 or more physicians annually. Now, if you've gone to a physician recently that's not a virtual visit, that could be a very long half a day, probably, if not even longer if you're traveling. Scheduling and managing physician visits can be time consuming too. How often do you wait online, going from one person to the next? And more than 1 in 3 dementia caregivers, 35%, coordinate healthcare needs, communicating with physicians, taking care of insurance issues, getting appointments, picking up medication, etc. At least one of those daily they take on, with some caregivers saying they coordinated care several times per day. We know there's a lack of care coordination in this country. That combined with the family caregiver involved in that role is really such a double whammy at times. Caregivers for people with Alzheimer's and other dementias provide approximately 26 hours of care per week. Additionally, a large majority of dementia caregivers surveyed spend years providing care, with nearly 1 in 2 acting as caregivers for 1 to 3 years, and almost 1 in 3 spending 4 years or more as a caregiver. So the need to coordinate this healthcare is common for these caregivers, and it's especially true for Black and Hispanic caregivers, who are more likely to be doing all of the above. They coordinate healthcare at least one day, while white caregivers, respectively, are less than that. So very concerning as a way in terms of testing our own competence and thinking about disparities in care. This likely influences the overall time spent providing care, with Black caregivers reporting the most time at 30 hours per week, followed by white caregivers 27 hours, Hispanic caregivers 25 hours, and Asian caregivers 19. So dementia caregivers experience difficulty and stress while interacting with the healthcare systems and addressing their own needs. A majority of caregivers surveyed indicate that coordinating care is stressful. More than half said navigating healthcare for the person they care for was difficult. Finding resources and support for their needs is also a challenge for 2 in 3 caregivers. So a high amount, which kind of has brought us to the work that we're going to talk a little bit more about today. So next slide. So what we found out is caregivers absolutely have higher levels of stress than non-caregivers, and caregivers with chronic stress may be at greater risk for cognitive decline themselves. Causes include managing multiple roles, adapting to new roles, complex medical ones, domestic ones, isolation, which we know has a whole body of work related to how isolation is impacting all of us, and physical demands, lots of physical demands. Next slide. And then we have clinically significant signs of depressive disorders are present in 40 to 70% of family caregivers of older adults, with about a quarter to a half of them meeting the criteria for a major depression. Caregivers are frequently strapped for time and energy, so neglecting their own care is normative. And 40% report experience 2 or more chronic diseases themselves. These issues are affecting millions of caregivers throughout the US, resulting in serious consequences for them, as well as the older adults for whom they provide care. That's why the struggle you often have and trying to get the family caregiver to look at themselves too. Sometimes the only way you can move them to that point is if you say, but if you don't take care of yourself, you hate to say this, you're not going to be around to take care of the person you're intending to take care of. So please take that time for yourself too. So some of the common challenges are about 58% of care partners engage in medical and nursing tasks, very serious ones. There have been literature upon literature, and somebody who heads up the AARP Policy Institute, Susan Reinhart, said, we ask caregivers to do what most nurses would be afraid to do on a floor with other nurses around if they needed backup. So we're sending them home around administering medications, wound care, handling complex medical equipment, all in the home. And sometimes without a place to call in the middle of the night when something is not working. 7 out of 10 of these caregivers also experience the practical and emotional burden of managing pain for the person they're looking after, which we know is so difficult too. The care is provided to the best of the caregiver's abilities, but few have received ongoing training and support from medical professionals and are rarely being asked, are you ready? Are you willing to do this? And if you're ready and willing, are you able? So why aren't we asking? Well, according to a 2022 study.
Next, can you advance the slide?
Sorry, next one.
One more.
Next one. Okay, so why aren't we asking? The challenges and approaches, there was a study done in 2022 by Riffin, and challenges approaches to involving family caregivers in primary care. And most primary care clinicians believe that it is their responsibility to recognize and involve family caregivers in routine medical encounters, but report ambiguity about when and how to engage families effectively and efficiently. So there's that disconnect often in primary care between theory, believing, and doing. And I think we all know that for different reasons. It's not to point fingers or blame, it's just very complex. Some are concerned that family participation will increase the duration and complexity of the encounter they might be in the middle of, and may also influence the content and dynamics of the consultation. Others I've heard say, well, what do I do if I find out or I dig more deeply? How do I handle it? Not always having a team around them to be able to help with these things, which would be very helpful if that happened. Other key highlights from the study are clinicians use varied approaches to manage patient-family interactions, and patients and caregivers prefer collaborating and patient-focused approaches that often don't get them. So with that study, I think there's a lot of salient features there that it's a perfect time to turn over to my colleague, Diane, to talk a little bit more about how we're handling all this at Rush. Diane?
Thank you, Robyn. So we aren't asking, so that's clear. We heard the statistics on that, and we know there's a lot of reasons for that. And most healthcare systems and providers are strapped for time. That's evident. But we all also know that there's evidence that shows if we support the caregiver, if we identify and understand and support the caregiver, the patient is going to fare better as well. So we want to find a way to engage that caregiver. And it starts with identification. right? That's really the key starting point. So how do you identify? We get that question all the time. I will say that many caregivers don't identify with that term caregiver or care partner. And in Europe, I think they use the word carer. But not everybody resonate, that doesn't resonate for everybody. So you have to find another way to ask. I'm not a caregiver, I'm a daughter. So, if you ask me that, no, I'm not a caregiver. So the questions, or one of the ways you can ask, is just asking, are you responsible for taking care of a family member or friend with a health condition, disability? And then you have to kind of name some of those tasks, because otherwise it could all of a sudden, I'm not responsible. But once you start listing those tasks, it's kind of like, oh, yeah, yes, I do. Yeah, I am, and then they add, oh, I also do this and that and transport and, make the medical appointments, etc. And then the other question is, if you're working with older adults or anyone, does somebody help you? Are you getting assistance? Because they may also be getting care. And there's several ways you can do this, because it sounds like, oh, another thing to ask, or I have to, but you can include that as part of the interaction with the patients, and that I'm going to go into, some ways that can happen. It can be included in the Medicare annual wellness visit template. We have that at Rush, that's automatically asked in that area. Or you can include it as part of your social determinants of health screening, which we also do at Rush. Next slide. So here's some examples on identifying caregivers. It can be at the pre-visit. I know I'm a caregiver for my mom, and so she gets a lot of notifications for check-in, the pre-visit check-in, they want you to complete that pre-visit check-in. It's the perfect opportunity to include that question in that pre-visit check-in. And that can be done, through MyChart, online, etc. And that just could be that same question, including that question in the pre-visit to ask if they, are receiving care or assisting somebody with care. Or it can happen at the visit. For example, it could be, the medical assistants or whoever does the rooming for the patient. Those questions can be asked even as, as they're kind of getting set up and they're asking some of those other pre-visit questions. Next slide. So once we've identified a caregiver, again, with those simple questions, and I'll talk about, once you do, what do you do once you've identified them? Of course, one of the things you would want to do is include it in the electronic health record, but I'll talk about that in a moment. But once you've identified the caregiver, you then want to assess their needs. So that's sometimes where there's the stopping point, right? It's like, oh, do I really have time to assess their needs? But again, there's a great benefit to doing that for that person that's in front of you, which could be your patient. You may not know that they're caring for somebody in addition to all the other things that are going on, because they may not just bring it up but if they're asked, they'll talk about it. So engaging then continues with assessing for needs. And what is an assessment? So a caregiver assessment is just like every other assessment. It's a systematic process of gathering information, but this time it's really about that caregiving situation. Not just about their, overall, but specific to the caregiving situation, so that you can identify if there's issues, challenges, but also their strengths, resources. And also kind of getting to that ready, willing, and able piece as well. What do they might have that readiness and willingness, but do they have the ability and the skills that they need to really contribute to the needs of the care recipient? And why? Why do we want to even assess? Well, we want to address those caregiver needs because that can maintain the health and well-being of those particular caregivers, which sustains their ability to provide care for the care recipient, prevent or postpone nursing home placement, which most Americans want to avoid. That's kind of one of those statistics as well. We want to age in place. We want to age where we want to age. And then produce better outcomes for the care recipient. And we have some data on that I can talk about in a minute. So our screening tools that we utilize at Rush are the following. I know everyone's probably familiar with the PHQ for depression. So we do that screening. We do the CADC for anxiety. We, of course, screen for social determinants of health, but we also use the burden scale for family caregivers short version. And that's a 10-item questionnaire that really hones in on that caregiving role. And I find, and we have found with using this tool, that it's really impactful when you start screening and using this with caregivers, because it helps them self-identify as a caregiver or as a person providing care. And it also really helps them get in touch with how it is impacting them. They may have not even given that a thought as to some point of how it might be impacting them, because they're in it, they're doing, as Robyn mentioned, you know, arranging the appointments, managing this, working, whatever else they're doing. They may not even have the time or don't even want to go there maybe to see or to really think about how it's impacting them. So this is that screener that really talks about that. And again, it's brief, but it gets right to the heart of it. And often it will elicit kind of that aha moment for them as well, and then connect them to, maybe I could use some support or resources. Next slide, please. And here's just a view of it so you can see, you know, I know it's a little, maybe not as crisp as I would have liked it, but it gives you an idea of what the questions are on the screener and how this might really open up their opportunity to, first of all, be heard, and to, nobody else is asking these questions. So we've heard that quite a bit too, like, oh my gosh, nobody, you know, family members, friends, nobody's asking me anything about how am I doing, or, you know, these particulars. So these are the questions that really hone in and allow them to, first of all, feel like they've been heard, feel like they're an important part of, like, their health is just as important as their care recipient. And again, kind of open the door for them getting some support. And if it's the provider that's asking, how important is either their provider or even their care recipient's provider? How essential it is that they're now involved in that way, and they feel like they are identified as part of that important dyad of caregiver and care recipient. Next slide, please. So again, probably wondering, like, okay, what, you know, how is this going to all happen? You know, it's, so this is really practical. You know, you have to think in those terms, like it can be very quick to identify and ask that question. It's just another question to ask, identify, okay, you are caring for somebody, and then kind of checking in on their needs. So again, if you do identify a caregiver and they're your patient, definitely document that in their record, right? You want to include that as part of one of those items that might be impacting their emotional and physical health. And you want to be able to address that with them, because it can be just as important as other issues. So assessing the needs, that might be a little trickier to do as a provider. However, you know, maybe the medical assistant can conduct those PHQ-GAD in that social determining during rooming. The provider can then maybe ask, you know, once you've identified they are a caregiver, the type of care they provide, ask them how it impacts their physical and mental health, and see, you know, what that response is. Maybe they feel like it is not impacting, and then you can check back on, and, you know, in the future or at a future visit. But also, if there is something that identifies, you could have a list of community-based caregiver support services or national local resource to provide to them at that time. So that might be something you might just want to have somebody compile. You know, there's, you know, I'll share that in a minute too. There's some very, I mean, you know, UCFS is a perfect example of some services and supports that are available, but that most area agencies on aging also have support. So there's a list that you can provide that can connect caregivers to support if you can't provide them internally. And then if you have social work or care management as part of the health system, you know, then the provider can just ask, would you like a member of our healthcare team to further discuss your needs and provide information on the resources? Next slide. So if a caregiver is identified as not your patient, so your patient is the care recipient, but you have identified that this person is providing care for your patient. So you would ask your patient if they want the caregiver documented in their patient's medical record. It connects directly with the CARE Act that's enacted in 45 states and territories. Although it's kind of focused on an inpatient setting, it's really best practice to ask and document both inpatient and outpatient. You can then ask the caregiver if they would like information on resources available and provide them with those resources, or, if you have social work care management, to ask that caregiver if they would like a member of the team to reach out. And additionally, community health workers, social workers, or care managers can conduct those assessments and kind of hone in on what matters to that caregiver, identifying their strengths, et cetera, during follow-up call and supportive resources provided. Next slide, please. So this is from the Alzheimer's Association 2024 Facts and Figures report. And so they did ask about what would be valuable specifically to dementia caregivers. And as you can see here, that high percentage of local caregiver support groups they'd like to be connected with, respite programs to give them a break, financial. We hear that a lot when we're working directly with our Caring for Caregivers program at Rush. They're looking for also just programs, workshops in classes, adult daycare, definitely disease information, including a 24/7 helpline, and legal help, which again, all of these factors, we hear caregivers talking about these supports. Next slide, please. So here are some resources that you could easily provide. There's a website called Best Programs for Caregiving, and they have identified and vetted a number of programs. I think it's somewhere between 45 and 50 programs specifically for caregivers that are caring for somebody with dementia or Alzheimer's. And these are evidence-based programs. And it can be for professionals to go ahead and look that up to see what's local in your community, but it's also consumers. Caregivers can also, so you can also give that information to the caregiver and they can see what's available in their area by just putting in their zip code. Of course, Alzheimer's Association, your area agency on aging, Department on Aging, Veterans Affairs, Family Caregiver Alliance, which is a national organization, and also the National Alliance for Caregiver. These are just easy resources that can be provided quickly to caregivers to provide them with a starting point for support. Next slide. And again, here's that website just so you have it for the Best Programs for Caregiving. It's free online directory of the top rated programs that support family and friend caregivers. Next slide. This is my lead in to the Caring for Caregivers program at Rush, because we are listed on that Best Programs Caregiving website as a evidence-based dementia care model. So we are rooted in the CARE Act, I mentioned that briefly before, and the 4 M's of an age-friendly health system, which in older adults identifies in all levels of care what matters: medication, mentation, and mobility. And I'll add that in our program for caregivers, we also include and identify and hone in on those 4 areas as well. Next slide. So our model that was created in 2019 with funding from the RRF Foundation for Aging, was really created because of what we just talked about, the statistics. The need was there. And we knew that if we supported that family caregiver, that we would see better results and health outcomes for older adults. So we developed the program to have 3 key things, which I've already kind of talked about, right? We want to identify and record those family caregivers in the older adults' health record. We also want to understand and assess the needs of the dyad. So that includes the family caregiver. So we're really looking at the care recipient and understanding their needs, but we're looking at that family caregiver as well and understanding, because there is that connection, and it's really hard to, especially when you're talking about dementia caregivers, they are really integrated into that care for that person. And then based on what matters to both of them, we want to work with them to identify resources and develop an individualized person-centered plan for them. Next slide. So what we offer at Rush is part of the model. So we use those assessments that I showed you with our caregivers, and then we work with them as an individual, because each caregiver is different, their setting is different, their resources are different, etc. And so we take an individualized approach to what they need. And we offer various things. First of all, we always connect them to resources that might be identified as we're assessing them. But we also offer things very directly, such as what we call planning for what matters sessions. So again, you can hear that 4Ms is in there. And these are brief psychotherapy sessions. And they're based on what matters to that caregiver and the care recipient. Usually these sessions are done just with the caregiver, but we can definitely do it with the diet if that's what they're looking for. Definitely open to that. But we find that many caregivers are kind of looking for that space for themselves to be able to come up with a plan, take care of themselves as they're providing care to that care recipient. These are usually between 1 and 5 sessions, but it can be extended as needs, are identified. We bill for these services through, insurance, and it's through the caregiver's insurance. If we do open a chart up for that caregiver, whether if they're a patient at Rush, obviously they already have a chart, but if they are not, we just open a chart for them for those services only. They are a patient of ours in the Caring for Caregivers program. The second thing we offer is referrals to what we call skill building meetings. These are referrals to PTs, OTs, and other professionals. And it's really to increase that caregiver well-being and increase their confidence in the care they're providing. So for an example, if a caregiver is doing transfers in and out of a wheelchair, etc., they may have never been shown how to do that effectively and safely so that they're not harming themselves and they're maintaining the safety for their care recipient. So that might be an OT evaluation, a referral for an OT evaluation. And of course, now with the new CMS codes for caregiver training, that's going to open up a wider array of services that we can support through these skill building meetings. The third thing we offer is what we call care team planning meetings, very similar to a goals of care meeting within the healthcare system. And it's just gathering that care team together. So the specialty, the primary, home health, if they're involved, the caregiver and the care recipient, and then focusing on what matters to that dyad and making sure that that's really discussed and is part of the goals of care. Next slide. So we do offer a full training on the model that we provide, and it comes with these workbooks that we've put together, which kind of gives you kind of A to Z on implementation, and we have a full manual on those sessions, the planning for what matters sessions. So it's a guide for clinicians to kind of walk through what are some of the common challenges for caregivers, and we also have a caregiver workbook that goes directly to the caregiver. And I will also say that in the model that we've implemented, we are following up with caregivers at 1 and 3 months, and we're following up with the PHQ and the GAD-7 and the burden scale to identify kind of checking in with them, first of all, at 1 and 3 months after they've completed their intervention, but also to kind of see, are we seeing better outcomes once they've had our intervention? And we have seen significant declines in all 3 of those areas at 1 month and 3 month post-intervention. Additionally, we ran data on, are we having an impact on the care recipient? So what we did was we looked at, for those that were receiving care at Rush, the care recipient, we looked at their utilization of the hospital 6 months prior to the caregiver receiving our intervention and 6 months post. And again, we saw really significant declines in ED visits, admissions to the hospital, and lengths of stay for those caregivers. So although we can't claim causality on that, we do see that if we are caring for the caregiver, it's very likely that we're having a significant impact on their utilization of the hospital. So support for implementation of the Caring for Caregivers model, which is a dementia care model, is at no cost for health systems. We're sharing it widely through a grant from the John A. Hartford Foundation. We provide those educational materials that I showed, and we're offering technical assistance throughout the implementation phase for all healthcare systems. Next slide. just wanted to show that we also offer a brochure. We can send that out to folks as well. And it's really for caregivers, it's really focused on the caregivers, but it incorporates those 4 M's. So we're addressing, we're kind of coaching caregivers to look at their own 4 M's and kind of check in on themselves, like how are they doing? What matters to them? What about mentation, medication, mobility for them, but also for their older adult that they're caring for. And we have that translated in Spanish and simplified Chinese as well. Thank you so much. This is where you would get in touch with us about the model or other questions. And hopefully we've got some questions that we can answer as well.
Thank you so much. We had a lot of great questions, so I think we will have a rich discussion, and I'll just encourage the audience to submit more questions as well. I think, I just really appreciate, once again, walking through the way you guys really support caregivers, the way you identify them so clearly, whether or not, and I just want to reiterate, like, if they're the patient, meaning you're talking to someone who comes alone perhaps, but you're sort of talking to them about their life and start to understand that they have a caregiving role, which is so important, and how you would then bill for caregiver support related activities. And then how you really assess their needs and how you create like resources and a system to support them and train them. You train them for the role, which is amazing. There were a ton of questions, so I think we should start up front with this about billing. So what you mean by how you incorporate billing into, and this may not at first sound like the most interesting part of the model, but I think what people are getting at is, oh, look how practical this is. This can be part of our actual care model as we're addressing the needs of caregivers. So the questions were roughly as follows. Sort of how are you doing that? Is this a Medicare or Medicaid billable service? And if you could just say a little bit more about how that really works, and understanding, I'm sure it's really complicated, but a little bit more detail to answer some of those questions.
Sure. So I currently, I don't think there's any billable service for identifying caregivers, right? So, that's, we're identifying them so we can then support them. And even the assessments, again, some of those are built into the hospital setting anyway, right? The PHQ and the GAD and the burden scale. You really can just ask a question about the caregiving role, and then if they're interested in support, direct them to services, then can bill for the assessment piece of it. So again, this can be a little complicated, but so we bill for the assessments if we're meeting with them in that initial psychotherapy session, because then we're doing a full assessment and we'll include those tools in that assessment. That's one way to do it. If for the psychotherapy sessions, we're billing through codes, psychotherapy codes. So we use licensed clinical social workers to do that work, but other providers can also bill for those services. And those are covered by Medicaid, Medicare, and a private insurance. So we bill the caregivers insurance, whatever insurance they have, we're billing for those behavioral health psychotherapy codes. So hopefully that makes sense for folks. For the skill building meetings right now, these are referrals. So once that caregiver does engage and gets a OT evaluation, it's that provider that's then billing for those services directly. We're just connecting that caregiver to the need that they have. We've identified that need, and so we're connecting them to that. But with the new CMS codes that have come out just in January, there's a larger opportunity for billing around caregiver training and support. So we have not incorporated that into our model as yet, but that's coming. And as we do, we'll be sharing that within the workflow that we have for our model. And then the care team planning meetings, again, those are generally, we coordinate, but those are generally billed as a goals of care meeting through the care recipient. I hope that answers the billing questions. And I'll just also note that as we're talking with sites, this is a very adaptable model. So we will work with you and talk about how can you bill for this, you know, what clinicians or supports, I mean, who do you have available to implement the model? Which could also include partnerships within the community. So you might not have to do all of this, but you know, you're identifying the caregiver, and then once you do, who's your partner to then connect to for this additional support? And we help with that and can connect you with that.
Okay, I think that does clear up a lot. So basically, if we're doing clinical assessments on the caregiver, doing some of these, you know, the depression, anxiety screen, SDOH, the burden screen, that's part of the visit. So there's codes that sounds like your materials help guide practices through if they want to include those. And then for the care recipient, if there's a larger planning meeting, a goals of care related sort of caregiver structured conversation, it would be for the care recipient. So I guess you have to be a little creative and thoughtful about like where all these pieces are going. And now we have additional CMS codes that are coming out or are out for caregiver training. Specifically, you can build.
And then, you know, thinking about it, it's, you know, as a dyad. So, you know, we're not used to that. Here's our patient in front of us, and we have to think of that dyad, and especially with dementia care partners, right? I mean, that, you know, that connection is so, you know, and so critical.
And we have an ongoing dialogue with CMS since the codes came out in January, constantly trying to clarify what it means and what it means for the different members of the team to be billing these codes too, with some advocacy along the way.
I think another series of questions were about the assessments themselves. So some people I think weren't totally familiar. So I just want to give you guys an opportunity to review one more time, like how you think about those assessments and how accessible they are in other languages. So there was a lot of questions about, you know, are these validated? Are they publicly available? And are they in other languages? And I tried to answer that, but I'd love to give you a second to just go over that again as well.
Yeah, thank you for asking that question. So they are validated screeners. Obviously, the social determinants of health, you know, that's kind of within our hospital setting. And so each hospital setting might have a little bit different, but that's also grounded in evidence, right? The questions asking and how important social drivers of health are to inquire. But the PHQ has been around forever. I know it's available in Spanish, but I really don't know the host of languages it's available in off the top of my head, but I'm happy to find that information, then send it forward. GAD-7, the same thing, that's been around quite a bit. I know that's also got some translations to it. And the burden scale, that also has some translations, but I don't know the list off of that, but all validated scales that we're utilizing, yes.
Great. That was the answer I provided, because I've definitely looked them up before and I've seen, then they're often validated because all of these have been around for quite a while. So they're usually validated in these languages. I also wanted to just put a plug. Somebody mentioned they noticed your brochure was in simplified Chinese, and they recommend also having a traditional version. Just putting that out there.
Appreciate that. Yeah, we're definitely expanding. This was just like our starting point. Like just to get the, you know, get it, but absolutely, we, you know, have other translated versions on the way, and thank you for that. Appreciate it.
Oh, absolutely. And just so the audience knows, in about 1 second, I'm going to put up some more information about Dementia Care Aware, how you can follow us, and also all the CME CE information will be live at 5 minutes to the hour, and I'll show more information about that as well. And it's in the chat already. I think another question that came up is the general, I don't know if you can speak to this, and I think there's a good opportunity to highlight where your program really fills a gap in a lot of areas, but what is the general accessibility of care management and you know, access to social work for people with dementia? My first reaction to that was I work in a place where not everybody with dementia has access to that by any means. It's just a limited resource. But I don't know if you guys have more to say about that, and also, again, how caring for caregivers helps address some of that.
That's a great question. Yeah, so at Rush, you know, we have a very large social work and community health department, and care management as well, kind of infused Of course, that took a long time and a lot of, advocacy, but, I think we're, maybe ahead of the game with that. And so it's hard to say what other healthcare systems, I know as we're talking with systems, not everybody has those same resources. But that's why we really kind of recommend and encourage partnerships within the community, because it's really about how do we provide these supports. If we can't do it within our system, but we're identifying folks, right? This is our opportunity for identify people with dementia and then those caregivers, and how do we best support that dyad, so it's really connecting. So it's the area agency. Aging is a great start. Behavioral health, those community behavioral health organizations that are in your community, et cetera, Department on Aging. And it's really gathering that team and who's doing what to provide all those services that are needed. So we do that as well, even though we provide a lot of it internally. We definitely are highly connected with our area agents on aging, because we don't provide respite. So there's services that they provide that we're constantly connected with them.
We also think there's a pathway of trying to build a capacity or a demand even more for social work or CHWs through this process.
Agree.
And that you could present business cases that hopefully would allow you to grow that critical part of your team.
This actually ties, there was an early question, more focused on the cognitive health assessment, which was really interesting about, can we do this in the community? Does it have to be in a primary care or health setting? And there are state models in Wisconsin and other places. And we have a partner in San Diego where they are doing it in a community center. They're screening for dementia and functional issues and caregiver resources. And then empowering the patient and whoever's with them or the client to seek out further services. The nice thing about that is if they're at a social services center or hub, they might have a lot more accessibility to that part of the care. And it's more the medical part around the cognition that needs more connecting if you're not in a healthcare setting. But I think this is also a really important piece of what you guys are doing. And what I admire so much is you're doing a lot more in the healthcare environment, but also the structure helps make it more effective to connect to community resources. And you're emphasizing all these high quality resources. And it is really, I know in our practice, super critical that we know what those resources are in our specific community so that we can make those referrals. But one solution I've found is just to have those relationships, keep up to date on what they're doing, how we refer, how we connect and try to do it. But I want to make one more plug for what you do, because I think the fact that you structure it for people, you structure the training, you structure the awareness and the identification of their role is like so much of the work that needs to be done. Because if we're sort of not making it really official and not really structuring it, it never sort of takes shape for the person as like one of the things they really need to be working on or accessing. Because I'm sort of constantly handing pamphlets or information about resources for training, but that it's really hard to engage. And I think part of that is just the structure that you guys provide.
Yeah, and I think that, thank you for pointing that out. I think what we appreciate and what people who are taking this on and implementing it are appreciating is that we're easy to adopt because we're also easy to adapt for their setting. When you think about person-centered care, we're, beyond person-centered care, we're about programmatic centered care or your health facility centered care too. And even when we're going out to places, like we're on our way to Atlanta tomorrow to train a group, we're trying to get the community-based organizations in the room as well. So that helps solidify those relationships too.
I think I just want to say, I want to encourage all attending to, we started out, you start at a starting point. There's always a starting point, and it's usually small and it's usually doable, right? And then you build. So I just encourage you to, consider it, reach out if you'd like to. I'm happy to chat through like what your situation and circumstances and kind of brainstorm around how you might get started. just open to that, because really our overarching goal is we want those caregivers to be supported for better outcomes for all, so happy to be a resource for you.
Any recommendations for ASL resources, things that are translated into ASL, or ways that you work with particularly? I know older adults who have acquired hard of hearing may be different than people who are born without hearing and then use ASL or ASL speakers. So but just wanted to ask if you have any tips for that population.
Well, I think I'll speak for our program. We, again, working with individuals, we kind of determine the needs of that individual and then, rally to make sure we can provide the cultural and the specific needs of that person. However, that being said, we don't have anything programmatically set in place to address that on a larger scale. So, so I think we have room for improvement in that area, for sure.
I will say, I know our community, our deaf community, has resources that have been like incredibly accessible and easy to work with. So anytime we need an interpreter, they're very, they make every effort to be available. And I've had great experiences and have never, it's one of the languages I've never had a problem being able to find an interpreter, even though they're not internal, they're offsite, and we have to arrange with them ahead of time to communicate. And then I found they tend to be very good resources for additional ways to connect that person to resources and support. So, if someone is somehow under-resourced in that area, they'll often identify it in the visit and help me connect them to more appropriate resources. We are at time exactly. And so I just want to, again, thank you so much for sharing the Caring for Caregivers program, which is growing. And as you pointed out, perhaps more and more usable as more of these billing codes and guide model gets set up and all of these things are changing. But thank you for sharing the model with us and teaching us all. It was absolutely fabulous talk. And I hope people do reach out and connect with the program and get your support to implement it. Thank you so much.
Thank you so much for having us.
Thank you all.